Hello, I'm Dr. Jason Ryan, and welcome to Module 1 of the Heart Talk series, Understanding the Science of Heart Failure. The first thing that's important to understand about heart failure is that it's a huge problem in the United States. There are currently over 5 million individuals living with this disease, and I put that in perspective for people by telling them that's about the population of the entire state of Maryland. There are over 600,000 new cases of heart failure diagnosed every year, and over 250,000 people die from the disease. Now, not only is heart failure common and very deadly, but it's also responsible for a very large number of hospitalizations. There are over 1 million hospitalizations every year in the United States for heart failure, and it's the most common reason for admission to a hospital in the United States. And the total cost of caring for heart failure patients to the U.S. healthcare system is almost $35 billion. Now, not only do heart failure patients tend to get admitted to the hospital a lot, but when they're discharged, they tend to just come back within about 30 days. Recent studies have unfortunately found that about 1 in 5 of every Medicare patients who are discharged from a hospital return within 30 days. And the most common reason for them returning to the hospital is heart failure. And I can tell you from my own practice as a cardiologist that many of these readmissions are preventable. If patients have a better understanding of their disease, if they have closer follow-up in the outpatient setting, they are less likely to come back in the hospital and more likely to stay healthy and stay at home. And that's part of the purpose of this video series, is to teach you so that you can empower your patients to self-manage their disease. Heart failure is the impaired ability of the left ventricle of the heart to pump blood. The heart is a muscle just like any other muscle in the human body. Its job is to squeeze and push blood forward to deliver oxygen to the organs of the body. If for any reason that squeezing mechanism is impaired and not enough blood moves forward, the symptoms of heart failure will develop. Heart failure has a classic triad of symptoms: shortness of breath, edema, which means swelling, usually in the ankles or lower extremities, and fatigue. When you listen to doctors talk about heart failure patients, you'll often hear them refer to the heart failure class of the patient. So it's important to know something about the heart failure classification system in order to understand and participate in that conversation. The New York Heart Association classification system was developed in the 1960s, and according to this system, a patient is New York Heart Association Class 1 if they have heart failure but they're entirely asymptomatic. A patient is Class 4 if they have heart failure and they have symptoms even sitting there at rest. Patients with Class 2 and Class 3 heart failure are in the middle. They have symptoms only with exertion. They're Class 2 if they have symptoms with significant exertion, and they're Class 3 if they have symptoms with minimal exertion. It's very, very important to understand that there are two distinct types of heart failure: systolic and diastolic heart failure. If you look at the screen right now, you'll see an echocardiogram of a patient with systolic heart failure. Notice that the walls don't move very much. And if you know something about what a normal heart looks like, you can also tell that this heart is stretched and dilated. This is a patient with a very weak heart. This is a patient with systolic heart failure. We normally give patients a number called an ejection fraction based on the findings on their echocardiogram. The ejection fraction is the percentage of blood which is pushed out of the heart with each heartbeat. A normal ejection fraction is about 55 to 65%. The patient whose heart is on the screen right now would have an ejection fraction of about 10 to 15%, severely reduced, and this is typical for a patient with systolic heart failure. This usually occurs after patients have had heart attacks and the heart muscle tissue has been replaced with scar tissue. Now if you look at the screen, you'll see the echocardiogram of a patient with diastolic heart failure. Notice that compared to the last heart, this heart is much more active and vigorous. And yet, the patient with this heart has the identical symptoms to the patient with the previous heart. This patient would also have shortness of breath, swelling in the lower extremities, and fatigue, but they have an entirely different problem in their heart. The problem with this patient's heart is that it is too stiff. When the heart is stiff, it can't fill with blood sufficiently, and therefore, even though each heartbeat is strong, not enough blood moves forward. This is what happens to patients with diastolic heart failure. We would give this patient a normal ejection fraction of about 60 to 65%. So it's very important to understand the distinction between systolic and diastolic heart failure, and the only way you can really tell them apart is by doing some type of imaging of the heart, since the symptoms typically are the same. Whichever type of heart failure a patient has, systolic or diastolic, they can be in one of two phases. Acute heart failure is when the patient is acutely fluid overloaded. They have extra weight on board, fluid on their lungs, fluid in their ankles. They feel very short of breath and very tired. This is acute heart failure, and this is what you typically see in the hospital setting. Once a patient's been treated for acute heart failure, usually with therapies to remove the excess fluid from their body, they now become a chronic heart failure patient. They may feel well, but they still have the disease. In this phase of the disease, patients require treatments to help them live longer and make them less likely to come back in the hospital with recurrent symptoms. So just to reiterate, the therapy for acute heart failure is very different from chronic heart failure. Acute heart therapy is generally aimed at reducing fluid congestion on the lungs and the rest of the body. You'll see these patients usually in the hospital. They're often treated with diuretics like Lasix. They may be given nitroglycerin. Sometimes we use a therapy called ultrafiltration, which is a type of mini dialysis that filters the blood and removes fluid. And in some special cases, we'll use inotropes. These are very powerful medications like milrinone and dobutamine that make the heart squeeze harder. These are drugs we only use in patients who have severe systolic heart failure, and is typically done in an ICU setting. Chronic heart failure therapy is very different. In this case, we're trying to lower the risk of recurrent heart failure or death. This is where you'll see drugs used like beta blockers, ACE inhibitors, spironolactone, or oral diuretics in the outpatient setting like Lasix. These drugs have very little role in the acute setting, but they have a very big role in the chronic setting where we want to stabilize patients and keep them well. The therapy for acute heart failure is generally the same whether you have diastolic or systolic heart failure. If you see hospitalized patients being treated for acute heart failure, no matter what their ejection fraction, no matter which type of heart failure they have, they'll often be treated with diuretics, often intravenous diuretics at high dosages. Lasix is typically used, but there are others. Nitroglycerin can be used for both forms of heart failure. Ultrafiltration, the filtering of the blood to remove fluid, can be used for both types. The one exception is inotropes. These powerful drugs are only for patients with very weak hearts. They make the heart squeeze harder, and as you can imagine, that wouldn't have much role in diastolic heart failure where the squeezing ability of the heart is intact. But by and large, the treatment for acute heart failure is similar between the two types. Chronic heart failure therapy, on the other hand, is very different, and this is where it becomes very important to understand whether your patient has systolic or diastolic heart failure. For patients with systolic heart failure, weak hearts, low ejection fractions, we have many drugs and therapies that have been proven to have great benefit. ACE inhibitors or angiotensin receptor blockers work very well in this situation. Beta blockers work very well. Aldosterone antagonists like spironolactone are used. Implantable cardiac defibrillators are often used in this situation, and there are many other drugs and therapies. Unfortunately, for diastolic heart failure, we have very few therapies that directly target the heart failure disease process. The best we can usually do in this situation is control fluid levels with oral diuretics so that patients don't become fluid overloaded. So once a patient moves out of the acute heart failure phase and into the chronic long-term heart failure phase where we're interested in stabilization, it becomes very important to know whether they are a systolic or diastolic heart failure patient so the correct therapy can be chosen. This is a sampling of some of the medicines you may see used in patients who have systolic heart failure. ACE inhibitors are often used. These are drugs like captopril, enalapril, lisinopril, and ramipril. Beta blockers are used, carvedilol, metoprolol. You may see hydralazine used. You may see angiotensin receptor blockers used like candesartan, irbesartan, and valsartan. Nitroglycerin is used, as is digoxin and spironolactone. Many of these medications are also antihypertensive, so you may see them used in patients with high blood pressure. But in the case of patients with systolic heart failure, they're being given to stabilize the heart and prevent the heart failure process from getting worse. Here's a sampling of some of the evidence that backs up the drugs we use in systolic heart failure. This is a slide from the Merit Heart Failure Trial, which was conducted in the 1990s. This shows the mortality rate of the two arms of that trial. In that study, about 4,000 patients with heart failure and low ejection fractions, systolic heart failure, were randomized to receive either a placebo or a sugar pill, or to receive the beta blocker metoprolol CR. And you can look at the two mortality curves here on the screen, and you can see that the mortality rate is significantly lower in the patients who took the metoprolol. There was a 34% risk reduction in the rate of mortality. And as I told you, with over 5 million people with heart failure, reducing the mortality rate by 34% means hundreds of thousands of lives can be saved by these drugs. And this is why it's almost imperative that patients who have a low ejection fraction in systolic heart failure receive a beta blocker unless they have a very strong contraindication. This slide shows some of the evidence supporting ACE inhibitors in chronic systolic heart failure. This is a study called the SOLVE-D trial, where patients were randomized to receive either a placebo, a sugar pill, or the ACE inhibitor enalapril. Thousands of patients with low ejection fraction and systolic heart failure participated in this trial. And as you can see, the mortality rate is significantly lower in the patients who took the ACE inhibitor, a 16% risk reduction. So ACE inhibitors, like beta blockers, form some of the pillars of our treatment for patients who have systolic heart failure. In that SOLVE-D trial, not only did patients on ACE inhibitors die less often, but they came into the hospital less often. You can see here the number of hospitalizations for heart failure in the two arms of the trial. In patients receiving placebo or sugar pill, there were 971 hospitalizations. In patients receiving enalapril, there were only 683 hospitalizations. That's a 30% reduction. So these drugs help patients live longer and stay healthy and stay at home out of the hospital. Everything I've been telling you about the drugs up to now has been for systolic heart failure, but what about patients with chronic diastolic heart failure? Well, as I said before, unfortunately, we really do not have a lot of drugs that directly target the disease. What we do for these patients is to carefully control their fluid levels with diuretics so that they don't develop a state of fluid overload. We treat their blood pressure because high blood pressure means that the heart has to do more work to pump the blood. And we try very hard to treat arrhythmias like atrial fibrillation. Patients who have diastolic heart failure really don't do well when their heart rate is fast and irregular, so we're very aggressive about treating atrial fibrillation when it occurs. This slide shows the rate of sudden death in several different populations. As you can see, in the general population, the rate of sudden cardiac death is very low. In patients who've had any previous coronary event, such as a myocardial infarction or an episode of angina, the rate of sudden death is higher. In patients who have a low ejection fraction, the rate is even higher, and the highest rate of sudden death is among patients who have already survived one cardiac arrest. We now know, thanks to several recent clinical trials, that certain patients with low ejection fraction will live longer if they receive an implantable device called a cardiac defibrillator to monitor their heart rhythm and deliver a shock if a serious cardiac arrhythmia develops. For this reason, you'll see a lot more heart failure patients, systolic heart failure patients, receiving defibrillators amongst your patient population. This is an example of what a cardiac defibrillator looks like. They've now gotten very small. They can fit in the palm of your hand. They're typically inserted just above the breastbone, under the left clavicle, and they have a wire that connects to the heart, and they are constantly monitoring the heart rhythm. And if they detect a malignant or dangerous heart rhythm, they can deliver an electrical therapy to break the rhythm and to restore normal beating of the heart. Current guideline recommendations for who should receive ICDs are for patients who have a weak heart, a low ejection fraction under 35%, usually with class 2 or class 3 symptoms. They need to be on medical therapy, and they need to have a reasonable expectation of survival with a good functional status for more than 1 year. There are some other therapy options for systolic heart failure that you should be aware of. Many patients with systolic heart failure are now receiving biventricular pacemakers. This is a special type of pacemaker that gets the heart to beat in sync. Some patients with heart failure and low ejection fraction have a heart that is out of sync, where one wall is contracting at a different time from the other wall. A biventricular pacemaker forces the two walls to contract at the same time to improve the function of the heart. It's very different from the type of pacemaker you may see in elderly patients who have slow heartbeats. Those pacemakers are being done to keep the heart from beating too slowly. In the case of biventricular pacemakers, the device is being implanted to get the heart to beat in sync and be more efficient. Some patients with chronic systolic heart failure go home on intravenous therapy with inotropes like milrinone or dobutamine, and you may encounter some of these in your practices. Ventricular assist devices are also called mechanical hearts, and these are indicated in some patients. And then also heart transplantation is an option. So depending on the particular setting where you practice, you may see more or less of some of these therapies. So to summarize, it's important to understand the distinction between diastolic and systolic heart failure. It's also important to understand the acute versus the chronic phases of heart failure and how the treatments are different for the two phases. And this information can help your patients self-manage, because patients who understand their disease tend to live longer and spend less time in the hospital, and they find a far easier time complying with medical therapy and lifestyle recommendations. Thank you very much.